Good morning, respected teachers, um, my seniors and dear colleagues. I am taking opportunity to give presentation on peritoneal dialysis in neonatal acute kidney injury. So, learning objectives for today's discussions are indications of renal replacement therapy, principle of peritoneal dialysis, PD catheters or PD solutions, PD methods, which are of two types, manual and automated, peritoneal dialysis technique, and complications associated with it, which may be infectious and non-infectious. First of all, renal replacement therapy is the process of removal of waste and excess fluid when a medical management fails to provide adequate renal support. So, coming to the indications of renal replacement therapy, first indication is fluid overload more than 10% body weight. In cases of dyselectrolytemia, we provide renal replacement therapy such in persistent hyperkalemia, persistent severe hypernatremia or hyponatremia, and in hyperphosphatemia, which may be associated with hypocalcemia. Also, just as in our case, in case of oliguria or anuria, there is indication for renal replacement therapy. Next, in uremia with bleeding or encephalopathy and blood urea nitrogen more than 150 mg per dl. In severe metabolic acidosis, also renal replacement therapy is indicated. There are other indications of renal replacement therapy like inborn error of metabolism such as hyperammonemia. Open heart surgery in neonate may lead to AKI, which needs renal replacement therapy, and inability to provide adequate nutrition is also an indication for renal replacement therapy. Now, coming to the types of renal replacement therapy, this is basically of three types. First is peritoneal dialysis, second hemodialysis, and third is continuous renal. Now, second hemodialysis and third is continuous renal therapy. Among these, peritoneal dialysis is the most preferred form of renal replacement therapy. Now, coming to the advantages and disadvantages of different dialysis modalities. So, first is peritoneal dialysis. It has the advantage of no need for vascular access or blood priming. There is no need for systemic heparinization. Peritoneal dialysis is slow and continuous removal of toxic products and waste products. There is lesser risk of hemodynamic instability, but it has some disadvantages like slower correction of metabolic parameters. Risk of peritonitis is there, and so it is contraindicated in patients who have severe pulmonary disease and intra-abdominal processes. Coming to hemodialysis, it has the advantage of rapid correction of metabolic abnormality. So it is the initial modality of choice in metabolic disorders such as hyperammonemia. It has the disadvantage of requiring vascular access, which is very difficult in low birth weight babies. Blood priming is also required. Risk of hemodynamic instability is high. Systemic heparinization is needed. Dialysis disequilibrium may be there because of rapid removal of toxins. So relative contraindications to hemodialysis are severe hemorrhage or hemodynamic instability. Coming to the third mode of renal replacement therapy, that is hemofiltration with or without dialysis. It is also a slow and continuous process with lesser risk of hemodynamic instability. Citrate-based anticoagulation are available at some centers. Removal of toxins and cytokines can also be done. It has the disadvantage of vascular access, and blood priming is also required. It can cause hypotension initially with bradykinin release syndrome, and systemic heparinization is also required in some institutions. Now, what is the mechanism of peritoneal dialysis? In peritoneal dialysis, peritoneal membrane is used to remove fluid, which is called as ultrafiltration, and restore balance of blood chemistries and filter waste product, which is done through diffusion or dialysis. So it requires peritoneal dialysis fluid, which is called as dialysate. The first process involved in the mechanism of peritoneal dialysis is osmosis, in which fluid removal is done, so called as osmotic ultrafiltration. The image shows container with a semi-permeable membrane. Osmosis is the movement of solvent from the area of low solute to area of high solute. The second process involved is diffusion, which is the process of movement of solute from area of its high concentration to its area of low concentration. So the image is showing movement of solute. The left side of the container had a high solute concentration. So it moved through the membrane, and the concentration of solute became equal on both sides of the membrane. Now, this is the peritoneal 3-pore model for water and solute transport in peritoneal dialysis. Dialysate is instilled into the peritoneal cavity, and then it is drained out through the drain into the urobag. When the dialysate remain in the peritoneal cavity, the peritoneal cavity is lined by peritoneal membrane, which has peritoneal capillaries. This peritoneal membrane, along with peritoneal capillary endothelium, has three types of pores. First is ultrapore. Ultrapore, it is about 1 to 2% in the peritoneal membrane. These ultrapores are responsible for the 40% movement of water from the peritoneal capillaries to the dialysate. And second pore is small pores, which is mainly responsible for the movement of urea, creatinine, small molecules, and water from the peritoneal capillaries to the dialysate. And third is large pores, which are approximate 5 to 7% of the total peritoneal membrane area. These large pores are responsible for the movement of macromolecules, that is IVIG or albumin. So now this is the slide showing the rate of molecular removal in peritoneal dialysis. The x-axis has dwell time in minutes, and the y-axis is the dialysate to plasma concentration of various molecules. As it can be seen that the molecules like urea and creatinine are removed quickly within 1 to 2 hours of the starting of peritoneal dialysis. So this is beneficial for us because the main aim of peritoneal dialysis is to remove urea and creatinine also. So this occurs within 1 to 2 hours of starting of dialysis, while large molecules like inulin and proteins, their removals are not achieved initially, and they take much longer time. So what parameters are used in peritoneal dialysis setup? First parameter is fill volume, that is the volume of dialysate filled in the peritoneal cavity for dialysis in one cycle. Small amount, that is 5 to 10 ml, and approximate 5 to 10 minutes. And third is dwell time, the time required for dialysate to remain in the peritoneal cavity for peritoneal dialysis. This is kept as 20 to 30 minutes. And fourth is drain time, that is the time required for the dialysate fluid to flow from the peritoneal cavity through the drain into the urobag. This is kept as 10 minutes. So this fill time plus dwell time plus drain time constitute one cycle or one exchange. So total one cycle time is generally kept as 60 minutes. Now, coming to the ultrafiltration, it is the net amount of water removed. Ultrafiltration is calculated as volume removed minus fill volume. We have to establish tables to log all volumes to calculate balance in ultrafiltration. This is the example of table showing first column is cycle time, second is PD input, that is the volume of dialysate instilled into the peritoneal cavity. Third column is for PD output, the volume of dialysate which has been flown through the drain into the urobag, and balance is calculated from the PD input minus PD output. For example, PD input was 80 ml, PD output was on 112 ml, so balance is minus 32 ml, and our ultra filtration is ultrafiltered volume is 32 ml. Now, coming to factors affecting ultrafiltration. So, as we have already seen in the case discussion, increasing dextrose concentration increases the amount of fluid that we can extract from the body. If the dextrose concentration is increased from 1.5% to 2.5% or to 4.5 or 5%, the fluid can be removed. More fluid can be removed. Second, if we increase the fill volume, it increases ultrafiltration. On increasing duration of dialysis as well as the number of dialysis cycle, ultrafiltration can be increased. Coming to factors affecting molecular removal, increasing dwell time, drain time, as well as fill volume can increase molecular removal. Also, it has been shown in many studies that increasing the temperature of dialysate from 20 degrees centigrade to 37 degrees centigrade increases solute clearance by 30 to 35%. Now, coming to instruments for peritoneal dialysis. From the right side, first is PD catheter with trocar, then urobag, then sterile gown, then spinal sheet, then burette, then kidney tray, and sterile gauge and trivim. So, what catheters are used for peritoneal dialysis? Different sizes can be trimmed and modified according to the size of the neonate. For this, we just have to keep in mind that distal fenestrated segment should be less than equal to 2 centimeters. Total length should be 10 centimeters, of which 5 centimeters approximate remain intra-abdominal. For acute peritoneal dialysis, we can use stiff or soft PD catheter. But if if stiff catheters are used beyond 48 to 72 hours, so there are chances of peritonitis. So for longer duration, we have to use soft PD catheter with tunneling, that is Tankoff catheter. And exit site for this should be outside diaper area to provide to prevent soiling and thus decreasing infection. Now, what are the types of PD catheters? So commercially available PD catheters are of following types. First is stiff PD catheter. Image shows stiff PD catheter along with connecting tube with blade. Second, soft PD catheters, that is Tankoff catheter. Length is 11 centimeters from proximal cuff to catheter tube. It is used when PD is required for more than 72 hours to prevent infections. This may be of the following types, like double cuff, which has the advantage of longer use and lesser infection. This is also of single cuff type. These are the modifications of Tankoff catheter. It may be straight, coiled, extended swan neck, single cuff, and double cuff. Swan neck catheters have the advantage of lower rates of exit site or tunnel infections compared with straight catheters. Also, curled catheter have the advantage of decreased inflow pain, less catheter migration, and less ball trauma. The image shows the curled catheter. Coming to the alternative to PD catheters. For neonates, commercially available PD catheters are not available. Also, extremely low birth weight in extremely low birth weight babies, we cannot put those catheters. So we should consider following alternatives for as PD catheters. First is femoral venous catheter, 14 gauge. Second, Cook 5 French catheter, which is an angiographic catheter. Third, angiocath. Fourth, suction catheter tip can also be used as PD catheter. Fourth, neonatal chest drain, as explained in the case discussion by Dr. Ankit, they used Malicot catheter for as peritoneal dialysis catheter. Sixth is IV cannula, 22 gauge can be used, 80 tube can be used. So this is the right image is showing 80 tube as indigenous PD catheter, and left side image is showing Tankoff catheter, which is placed surgically for peritoneal dialysis. So this study was published in 2021. They used 4 types of tubes for peritoneal dialysis: 14 gauge gastric tube, 10 gauge aseptic inhaled phlegm pipe, neonatal PD catheter, and 12 gauge urethral catheter. They concluded that the length of the straight dialysis catheter may increase the risk of bowel perforation. So we can modify these tubes according to the size of the neonate, and they noticed no complications with the use of these catheters. This study was published in 2013. They use IV cannula in the extremely low birth weight baby as a PD catheter, and no complication was associated with this, but the baby succumbed due to the condition for which peritoneal dialysis was started. This study was published in 2018. In this, they used 14 gauge single lumen central venous catheter, which served as a PD catheter, and 10 units with AKI were treated using this. Peritoneal dialysis using this was simple, safe, and effective. Now, coming to the access site for the peritoneal dialysis catheter. So, from the left, the image shows a peritoneal dialysis catheter was placed in the right lower abdominal quadrant, and in the middle image it shows that a peritoneal dialysis catheter has been placed in the midline below the umbilicus. In the rightmost image, the PD catheter is placed in the left lower abdominal quadrant. So the most common site is just below the umbilicus in the midline. It can also be placed in the right and left lower abdominal quadrant. But in a study of 2014, the PD catheter was placed in the left upper quadrant also, and no complications were noted in this. So we can also use this quadrant. Now, coming to the PD fluid or dialysate, commercially available peritoneal dialysis solutions are of the following types. First is regular calcium, regular magnesium with sodium concentration 132 milliequivalent per liter, calcium 3.5 milliequivalent per liter, magnesium 1.5 milliequivalent per liter, chloride 102 milliequivalent per liter, and lactate 35 milliequivalent per liter. The other two types are regular calcium, low magnesium, low calcium, and low magnesium. These 3 types of peritoneal dialysis solutions are available in 3 pre-mixed dextrose concentration, that is 1.5%, 2.5%, and 4.25%, which can be used according to the condition of the patient. This is the image showing Baxter Daniel low calcium peritoneal dialysis solution with 1.5% dextrose. It is also available as 2.5% as well as 4.25%. Now coming to the modifications in PD prescriptions. So what modifications we need to do in peritoneal dialysis prescriptions according to the condition of the patient. First condition is fluid overload. We can use higher gradient PD fluid with 2.5% or 4.25% solution if we need more fluid to be removed. It can also be prepared by adding 25 ml of 50% dextrose to 1 liter of 1.5% PD fluid. For fluid overload, dwell time can also be increased, and we can increase the number of cycles and increase duration of dialysis. In case of liver failure, asphyxia, hyperlactatemia, and hemodynamic instability, we have to use lactate-free bicarbonate PD fluid because already there is lactic acidosis. So for this, we can modify PD fluid as we can take 440 ml of 5% dextrose plus 60 ml of soda bicarb, which is labeled as solution A, and 500 ml of NS is labeled as solution B. Then we have to take 1/3 of solution A plus 2/3 of solution B. This makes the lactate-free bicarbonate PD fluid. Coming to hypokalemia, if the patient's pre-dialysis serum potassium level is less than 4 milliequivalent per liter, then we have to add 4 milliequivalent per liter KCl in the dialysate fluid because the commercially available dialysate fluid does not contain potassium. If the pre-dialysis serum potassium is in between 4 to 6 milliequivalent per liter, then we have to add potassium chloride 2 milliequivalent per liter. But if the serum potassium is more than 6, then there is no need to add KCl. If hemorrhagic effluent is present, we have to add heparin 250 to 500 unit per liter in the dialysate. For solute removal, like in hyperammonemia, hyperlactatemia, uremia, toxins or poisonings, we have to increase dwell time. In case of hypernatremia, dwell time is increased and lower glucose concentration of dialysate is used. If we are having hyperglycemia in the patient, then we can decrease the dextrose concentration if possible, and if it's not possible or the hyperglycemia is not corrected, then we can add insulin. Dose is 4 to 5 units per liter if we are using 1.5% dextrose solution, 5 to 7 units per liter for 2.5% dextrose solution, 7 to 10 units per liter for 4.25% dextrose solution. For supplementing calcium, supplemental calcium should never be given through PD solution because it may be it will precipitate with bicarbonate. In case of hypernatremia with acute kidney injury, we have to add 3% or 5% hypertonic sodium to within 15 millimole of patient serum sodium for gradual reduction of serum sodium. Otherwise, it will lead to cerebral pontine melanosis. Now, coming to endogenous PD fluid. This should always be considered in case of emergency purposes when commercially available PD fluid is not available. This can be prepared as follows. Sodium bicarbonate 35 ml is taken and it is mixed with dextrose 300 ml with 649 ml of normal saline, and then 14 ml of distilled water with 1.8 ml of magnesium sulfate. This will make 1 liter of endogenous PD fluid with dextrose 1.5%, sodium 135 milliequivalent per liter, chloride 100 milliequivalent per liter, bicarb 35 milliequivalent per liter, magnesium 1.5 milliequivalent per liter, and sulfate 1.5 milliequivalent per liter. But this should be only used in emergency purposes. Now, coming to modalities of peritoneal dialysis, basically of two types. Manual PD, it is reliant on gravity, simple performance, limited cost of equipment, but it is labor intensive. In automated PD, cycler is there, so there is decreased need for constant monitoring, shortened fill or drain times. It has decreased rates of peritonitis, and main disadvantage is decreased ability to perform at fill volumes less than 60 to 100 ml. So we cannot use for low birth weight or extremely low birth weight babies. Then coming to the PD prescription, what all should include before starting peritoneal dialysis. This include, first we have to decide dialysate composition with additives as already discussed. Exchange volume is generally kept as 20 to 30 ml per kg, starting with lower volumes and then proceeding till 20 to 30 ml per kg. Inflow time and outflow time, which is kept in approximate 5 to 10 minutes. Then we have to decide dwell time according to the condition of the patient. This is kept in between 30 to 45 minutes, and total cycle time is kept for 60 minutes. And frequency and duration of exchange, initially hourly exchange for 44 hours per day, followed by 8 to 15 hours per day if chronic peritoneal dialysis is required. And Also, we should write monitoring of patient's vitals, fluid intake output, and PD fluid for signs of peritonitis in the PD prescription. So now, coming to the peritoneal dialysis technique. This is a video showing the technique of peritoneal dialysis. First, we have to empty the bladder by catheterizing, and then we have to prepare the abdomen of the baby by draping aseptically. After cleaning the part, we will proceed on for peritoneal dialysis catheter insertion. For this, we are using stiff catheter, but if it is required for 48 to 72 hours, then we need to replace it with soft elastic catheter, that is Stankoff catheter. We are placing guard so as to prevent deeper penetration. The length of the PD catheter is trimmed according to the neonatal size, and then the depth of insertion is decided by approximating the distance between the umbilicus and the anterior superior iliac spine, and accordingly the guard is placed. Then continuing with the local anesthesia, we have to infiltrate the skin around the PD catheter insertion site with topical anesthesia. We are going to insert a PD catheter just below the umbilicus in the midline. So we are infiltrating with topical anesthesia. Next, we have to create reservoir in the peritoneal cavity because if we directly puncture the abdomen with the PD catheter, then it may cause trauma to the bowel. So first we have to create a reservoir using 22 gauge cannula, and then instill a 20 ml per kg of warm dialysate into the baby's abdomen, that is into the peritoneal cavity. And with the use of this, the bowel get displaced. So when we will insert peritoneal dialysis catheter, it will not cause trauma to the bowel. Then after removing cannula, we have to give horizontal neck at the site of insertion of PD catheter. Then we have to insert PD catheter holding the guard, and with the help of the other person, we are inserting PD catheter through the boarding technique. After securing peritoneal dialysis catheter through a suture, then we will attach the connecting tube, and with the help of the tri-way, we will create two circuits: the outflow circuit, which is connected to the drain through the drain to the urobag, and the inflow circuit is added to the other port of the tri-way. And inflow circuit constitute the pediatric burette, through which dialysate is instilled into the peritoneal cavity through the peritoneal dialysis catheter. And the outflow circuit consists of the PD catheter, tri-way, and drain to the urobag. Then we have to check the adequacy of peritoneal dialysis competency of peritoneal dialysis catheter. For this, we have to open the tri-way of inflow circuit, and then we have to instill dialysate fluid into first in small amount 5 to 10 ml per kg into the peritoneal cavity. After the dwell time, we have to open the outflow circuit and check the fluid coming out through the drain into the urobag. So this completes one cycle of the peritoneal dialysis. This is the chart we are using for peritoneal dialysis. In this, we have to document patient's name, CR number, date, and day of PD. And columns we have to write in time, in volume, well time, out volume, and we have to calculate total balance. Now, coming to the nutritional requirement for the patients on peritoneal dialysis, goal is to give 100 to 140 kilocalorie per kg per day for optimum growth. And a patient on dialysis receive 20% calories from absorbed dextrose or dialysate, and protein intake of about 2.2 gram to 2.5 gram per kg per day is required in view of loss of protein in dialysate. Formulas low in phosphorus and potassium are chosen because they're already increased potassium and phosphorus. And nearly all patients on PD need nasogastric or jejunostomy feedings. Vitamins and mineral supplementation is done. Also, dialysis causes sodium loss, bicarbonate loss, and phosphate loss. So we need to supplement all these. Albumin infusion is also required to maintain serum albumin 2.5 to 3 gram per DL. And carnitine supplementation is also required because carnitine is also lost in the dialysis. The role of IVIG supplementation is controversial because of the risk of anaphylaxis. Now, what parameters we need to monitor during and after peritoneal dialysis? Vital signs, pulse, respiration, BP, SpO2, temperature, continuous monitoring is required for this. Fluid input and output monitoring is required for 8 to 12 hourly, and as the patient of the and as the condition of the patient is there, and weight charting is done 12 to 24 hourly. Continuous CVP monitoring is required in selected cases. Blood sugar 4 to 6 hourly should be done, and serum urea, electrolytes, creatinine, and calcium should be done 12 hourly, and as per the condition of the baby. And CBC needs to be done once daily. Now, the complications associated with peritoneal dialysis. Main complications are catheter leak and hyperglycemia. So coming to the PD catheter leak, first we have to confirm the diagnosis with leak with glucose dipstick. For this, we can discontinue dialysis or low volume dialysis can be done. And the site of the catheter also needs to be changed. For outflow failure, first we have to confirm by doing abdominal X-ray, and fibrin can be removed with flushing using heparin and repositioning PD catheter. If patient is having dehydration, then we have to ensure adequate oral intake or IV fluid, and we can also decrease PD dextrose concentration in case of dehydration or hypotension. For fluid overload, we have to reassess dry weight, decrease fluid or salt intake, increase PD dextrose concentration, and we have to reassess fluid intake and output. For hyperglycemia, we can decrease dextrose concentration if possible, and if not possible, then we have to add insulin. Dose is 4 to 5 units per liter for 1.5, 5 to 7 for 2.5, and 7 to 10 units per liter for 4.25% dextrose solutions. In case infection is there, we should suspect peritonitis if patient is having fever, irritability, vomiting, diarrhea, or feed intolerance. For this, PD fluid should be sent for cytology, gram staining, and culture. Cloudy affluent fluid favors peritonitis, and if the affluent cell count of more than 100 WBC per ml is there with polymorphs more than 50%, it confirms peritonitis. For this, systemic or intraperitoneal antibiotics need to be started. First, we have to do 2 to 3 rapid PD exchanges, followed by loading doses of vancomycin and ceftazidime, which is vancomycin loading dose is 500 mg per liter, ceftazidime 250 mg per liter, followed by maintenance dose of vancomycin is 30 mg per liter, and ceftazidime is 125 mg per liter. Heparin is also added because peritonitis leads to increased fibrin deposition, and continuous dilation 24 hours per day is done. If we are suspecting fungal peritonitis, prophylactic antifungal therapy in form of oral nystatin and fluconazole needs to be added. But if it is confirmed, mainly Candida species is there, so PD catheter removal is necessary in case of fungal peritonitis. And what is eosinophilic peritonitis? In this, the patient is asymptomatic. Only cloudy PD fluid is there, and on doing lab investigation, eosinophils more than 10% of total polymorphonuclear cells is present. So basically, eosinophilic peritonitis is an allergic reaction to the PD catheter composition. Nothing to be done, only spontaneous resolution is there, but reducing dextrose concentration and time of PD enhances spontaneous resolution. So coming to the contraindications of peritoneal dialysis, severe pulmonary disease, omphalocele, gastrochysis, diaphragmatic hernia, and NEC is absolute contraindications, while recent abdominal surgery, pleuroperitoneal communication, abdominal wall cellulitis, and severe GRD are relative contraindications. Coming to the neonatal peritoneal dialysis SGPJ experience from 2019 to 2021. Total number of babies with AKI were 32. Among this, 21 patients underwent peritoneal dialysis. This is the characteristic of the patients who went peritoneal dialysis. Birth weight was in between 2,200 gram plus minus 430 gram. Gestational age was in the 34 plus minus 2 weeks. 71.4% were outborn and 76% were male. Age at dialysis after diagnosis of AKI was 8 plus minus 3 days. So in our patients, the most common indication of peritoneal dialysis in 71.4% was rising creatinine and oliguria. This electrolytemia was there in 90.1% patient, and fluid overload was present in 9.5% patients. We used STIP catheter in 67% patients, Tankoff catheter in 24% patients, and endogenous catheter in 9% patients. Most common complication of peritoneal dialysis was peritonitis, which was seen in 24% of patients, and obstruction was second, which was seen in 19% of patients, and bleeding was seen in 9.5% of patients. So among the patients, 71% succumbed to death because of the condition for which PD was started, and 29% were discharged. So this is the comparison of peritoneal dialysis from various study. First study is Kara et al. Of 2017. It was a retrospective study. Need for dialysis was in 78.8% patient with hyperglycemia as the most common complications. It was seen in 48% of patients. Mortality was 77%. In the study of Okan et al. 2020, 2.8% needed dialysis. Leak in 28.5% was the most common complication, and mortality was seen in 81% of patients. In IGPGI, it was a retrospective study. 65.6% needed dialysis with peritonitis was seen in 24%. It was the most common complication, and mortality rate was 71%. So take-home messages: early initiation of RIT should be considered before organ failure. Easily available, peritoneal dialysis is easily available in resource limited settings and is also technically simpler. PD is appropriate in acute setting, not dependent on large numbers and well-trained staff. PD is more suitable for hemodynamically unstable neonates as well as practical for low birth weight neonates as they have difficult vascular access. Peritoneal dialysis should be carried out aseptically with fluid input-output monitoring for effective dialysis. Thank you.
Thank you very much, Preeti. I think maybe we can start if there are any questions or comments.
First, I'd like to congratulate Dr. Preeti. Excellent presentation, especially the modifications of peritoneal dialysis fluid, very well presented.
Thank you, sir.
And I must say, like Dr. Ankit, he presented the case very well, although we've seen that the outcome was not good, but that is what has been seen in most of the, like what is presumed is that the outcome, like mortality after the procedure is high, but it is actually because often the replacement therapy or dialysis is considered already when the multi-organ dysfunction has set in, because most of the times, like it is we're still hesitant to start the baby on to take the baby on early peritoneal dialysis. Actually it will help if it is done as soon as the AKI is set in and before the other organ dysfunction has set in. But if it is done on time and done in a, like, because we have seen that it is not that much technically difficult also, so it can really bring about huge change in the outcomes of the babies that we are handling. And now more often there are so many case series, case reports coming up, even where peritoneal dialysis is being used in 600, 700, 800 grams baby. So the size of baby should no longer remain a constraint in that. So I think if there
I agree with you, Dr. Akanksha. I think we should go ahead with the visual quiz first. Dr. Chinmay?
Yes, sir, sure, sir. Dr. Ankit, can you please share the presentation?
Yes, sir.
Yeah, thank
showing
you.
the spotter of the outboard 39-week
No,
baby,
I'll do that. I'll do that.
3.2 kg birth. This baby was home delivered and presented to
Hello.
us with. Sure, sir.
I'm sorry. So this
Hello.
is an
Yes, sir.
outbound 39-weeker, 3.2 kg, who was referred to at us at day 4 of life. The baby was home delivered. They went to some private hospital in which they gave the baby some respiratory support. Then they referred to us at day of life 4. The baby had HI2 with multiple seizures, and the baby had feed intolerance. The baby had abdominal distension, the sluggish bowel sounds, and the baby was not passing stools. And there were some RT aspirates also. We got an X-ray done, and this is the X-ray we got. So I want to ask that the radio opaque shadow, which you can see in this X-ray in the abdomen. So can anyone of you guys tell me what it is? Anyone? Any fellow from GPGI or HIMS? All right. First, let me show the another X-ray which we got after 24 hours of admission. Ankit, next slide. Yeah. So after 24 hours, still the feed intolerance persisted. We were not able to start the feeds, but then that shadow had gone within 24 hours. The previous slide, yeah. So anyone of now can try. Any guesses?
Is it like, our faculty also allowed to speak?
Sure, ma'am. Sure, ma'am.
Not to begin with, Kirti. Not to begin with. Okay, later.
Okay.
Yeah.
Any fellow, any DM resident want to try? Any guess at least?
Any guesses at least?
Yeah, if there are none, then faculty, but it is not good. The exercise is not for the faculty. It is for the fellows. You don't know what's the answer. Yeah,
Sir, as the
anyone,
baby,
come on.
as the baby is day 4 of life, so can be it can be either the like intraperitoneal calcification or meconium, or can it be umbilical cord, shriveled umbilical cord?
Well, yes, it can be either of these things. So we have to evaluate for both the things. One, if it is a meconium calcification, then the other abdomen is perfectly fine, right? So but we had kept that possibility also. But then after getting the X-ray repeated after 24 hours, this radio opaque shadow has clearly gone away. And then so we retrospectively evaluated, and the baby's
Let us listen to Professor Kirti as well. Okay,
yes.
you continue. Yeah, someone speak.
So is this the shadow for the umbilical clamp which is being taken?
Okay. Well, the baby didn't have umbilical clamp, cord clamp. Actually, it was tied by a thread when we saw it.
Please go ahead with.
Yes, sir. So we had kept both the possibilities, but since the radiopaque shadow had gone away after 24 hours in the repeat X-ray, and when we retrospectively evaluated the baby's cord had actually fallen away. So we made the diagnosis of shriveled umbilical cord only, though we don't expect that the umbilical cord would be radiopaque. But in this case, if we see clearly the first X-ray, Ankit, the first X-ray. Yeah. So in the distal 1/3, we can actually see a tie. There's a knot, which is due to, yes, which is due to the thread itself. So it was nothing but, as Garima said, it was the umbilical cord only. Though, as I said, it's not supposed to be radiopaque, but maybe due to the shriveled, or maybe there's some calcification, or due to its dryness, I don't know, we don't know, but it was umbilical cord only. So the message is that whenever we get such aberrant radiopaque shadows, we should see completely. We should get a repeat X-ray, and we should also see from top to bottom, like any artifacts, any shadow which can cause shadows. So we should see whether there was an in temperature sensor probe or any other wire, the umbilical cord, umbilical clamp, as one of you said. Then we should go inside and see what all pathologies can cause that shadow. Thank you. That's it from my side, sir.